Simon Khatra, who is a second year University of Leicester student. And he took on the daunting topic of gastrointestinal issues in Marfan syndrome. Now, we've heard from our speaker this morning in great detail about Ehlers-Danlos syndrome, but there doesn't seem to be much in the literature regarding Marfan syndrome. So we were hoping that Simon might be able to fill this in for us and suggest future work. Simon.
Thank you for the introduction, and it's going to be difficult to follow on from those two great presentations from Elsa and Lakshmi. But as Dr. Child mentioned, I'm Simon Khatra. I'm a second-year medical student, and during the summer, I conducted research with the Marfan Trust investigating the gastrointestinal manifestations within the Marfan population. So just as a brief order of things, I'll start off with an introduction to Marfans, which I'm sure you are very familiar with, multidisciplinary teams, the gastrointestinal complications, functional or motility disorders, structural complications, and ending with a conclusion and time for any questions. So just a brief introduction into the typical presentation. I'm not going to dwell on too long about this, but this picture sums it up quite nicely. So the classic heart problems, eye problems, and also the long limbs and joints. This was a really good paper I found, and it just highlights just how many different clinicians and specialists are involved in the care of someone who has Marfan syndrome. So on the left, it's listed all the different doctors, etc., and on the right, what they actually do. And I've just summed it up in this page. So everything from a cardiologist to a geneticist, a heart surgeon, orthopedic surgeon, and also even radiologists and neurologists, etc. But the main thing I just want to take away from that is, as you can see, gastroenterologists, so doctors who look after the GI system, they are not mentioned. And so why did I actually decide to investigate gastrointestinal symptoms? The main reason is just there is a pure lack of existing research. And the reason behind this is it is due to the small number of the population who actually experience gastrointestinal problems. So on the previous image, it showed the classic eye problems, the classic heart problems, the joint problems. This is where the research is focused, simply due to a greater proportion of the Marfan syndrome having these traits, whereas gastrointestinal symptoms are relatively rarer compared to those. So I decided to split the two main groups of people who experience gastrointestinal complications as follows. The first group looks at functional or motility disorders with symptoms similar to those seen in irritable bowel syndrome. This can include constipation, abdominal pain, etc. And the second group I've split into structural complications. As I progress with my presentation, I would like to highlight that despite my presentation showing that the second group might be larger, I would like to highlight that this is most likely not the case. The scientific literature simply shows more structural complications, given to the fact that it gives researchers something to write about because it is extremely, extremely rare. So, for example, if you have a patient who has diverticulosis and Marfan's, this combination is extremely rare, and therefore the researchers publish their research showing that they might be the first one who has this. And so then other people chip in with other combinations, such as a hernia and Marfan's. So hopefully that makes sense. The reason that there are more papers with the second group as opposed to the first group is that the number of people with Marfan syndrome who experience GI complications is already a low number. And this requires a lot more work with the first group, surveying a lot of people and writing a full paper, as opposed to the second group, where it's simply a case report on an interesting case. Initially, my presentation was going to be looking at all the scientific literature, highlighting the main methods and the results, but frankly, it was far too boring. So I've highlighted and distilled the main bits, and I've also included some anonymized responses from Marfan patients who graciously agreed to be interviewed. So I'm going to start with the first group. functional or motility disorders with symptoms similar to the ones found in IBS, irritable bowel syndrome. I promised I wouldn't be talking about too many papers, but I think this is a really good, just super brief summary. So this paper, it looks, I've split it with the 2 arrows, but it shows on the left, the Rome 3 classification, but also you can use the Rome 4, which is an upgraded version of this. And on the right, a quality of life questionnaire. So in this paper and in a couple others, they looked at the different GI symptoms and they classified it as the Rome classification. So as per esophageal disorders, gastroduodenal disorders, functional pain, bowel disorders such as those found in IBS. And then they also completed a quality of life questionnaire. So this was just from 0 to 100. And then, as it says on the name, just a quality of life. So how the patients actually felt on a day-to-day basis. And this includes everything from physical health to more emotional health. I've just included on the right the words statistically significant. I can write a list of all the different papers and send it if anyone would like to read it in their own time. But if you do come across any papers, I would like to highlight the words statistically significant. This is important when reading a paper because it's not just enough to say that these amount of people with Marfan syndrome experience these GI symptoms. It's important then to compare it to your normal healthy population and to see if it is truly significant. So if you have a normal healthy population, which has constipation and abdominal pain, is it actually less than someone in a Marfan population? So that's just what those two words mean. So the typical presentation, it was some of the papers varied in terms of saying if it was actually more than the general population, but I've included it here. So constipation, abdominal pain, bloating, dysphagia. Dysphagia is just struggling to swallow. All of these were mentioned in the papers. And in addition, the last three, pain in bowels, vomiting, and acid reflux, this was mentioned by some of the interviewees in which I interviewed. But as you can see, they are all linked. Vomiting and abdominal pain, they are all interlinked. And on the right, I've just included that one recent study showed that 40% of the Marfan syndrome patients, as opposed to 15% of the control group, reported some of these symptoms, such as constipation, etc. And interestingly, they also found that women had higher rates of bloating and constipation when compared to their male counterparts. So some of the treatments can include a change in diet. Everyone that I had interviewed found that by changing/improving their current diet, changing out on healthier options for healthier alternatives usually improve their symptoms. Moreover, by tackling and changing specific food items, this could be an effective way to track which certain foods may exacerbate or reduce the symptoms that they were experiencing. Oftentimes, by increasing the amount of fiber in the diet, this led to a reduction in the GI symptoms, and this was also repeated in the scientific studies. Exercise and eliminating stress can also help, and of course, specific medication. I will not be focusing on specific medication because it would be too difficult to generalize, but simple things like laxatives to treat constipation, etc. So now I'll move on to the structural complications. As you can see on the left, there is a large array of different structural complications which can occur. And despite it seemingly being longer than the functional or motility disorders, as mentioned, these are simply reported because they are usually very small one-off cases. And I've summarized it on the right because the left is probably too small to view on the computer. So things such as diverticulosis, paraesophageal hernia, diaphragmatic hernia, sigmoid volvulus, and hiatus hernia, as well as different combinations, so such as a hiatal diaphragmatic hernia, etc. And I promised I wouldn't talk too much about the papers itself, but I found this paper was particularly useful. So it's titled Features of the Marfan Syndrome that are not listed in the Ghent nosology. The Ghent nosology are, it's basically a list of the characteristic traits, such as the eyes, the heart, and specific parameters, the dark side of the disease. So I'll just talk about this paper. The authors of the article, this was a German paper, and they defined the term dark side as what we experience quite often as symptoms which the people thought may belong to Marfan, but do not show up in official descriptions or in official patient guides. So these are not routinely checked by medical experts. So it presented a list of symptoms and complaints, which they got from three main sources. The first were notes that they took from many telephone consultations with members of the organization. The second was from information collected from their own Marfan Facebook group in Germany. And the third was asking the members and visitors with Marfan syndrome on their official German Marfan International Day. So much like this International Day, their own German, the 23rd International Day. And so this were just screenshots. I've taken the subtitles and the headings from the abdominal section of the paper, and liver and kidney cysts, biliary tract features, diaphragmatic hernia, as previously mentioned, and also other abdominal features such as diverticulosis, volvulus, etc., and also adiposity. So these are all further abdominal features, structural complications, which could appear in someone with Marfan syndrome. And in conclusion, it says that all of these potential abdominal issues, as well as cardiovascular ones, should be considered in any person with Marfan syndrome presenting with abdominal features, particularly in older patients. So it's just highlighting that despite the main cardiovascular, ocular, meaning eyes, traits, we should definitely focus on the gastrointestinal complications. And on the left, I've just further summarized that there are more volvulus, diverticulosis, and they all have the same conclusion that further research is needed in this area. And if someone does present with this, it could also be due to the Marfan, due to them having a diagnosis of Marfan syndrome. I would just like to end with a big thanks to the whole of the Marfan Trust, in particular my supervisor, Dr. Child, for her vast knowledge and guidance throughout the project, Victoria Hilton for helping to arrange the patient interviews and the GI webinar, and lastly but not least, the patients in the Marfan Trust who agreed to be interviewed, and hopefully their anonymized experiences will help increase the awareness and potential of the gastrointestinal complications in the Marfan population. So just to conclude, Marfan syndrome is a connective tissue disorder which can affect multiple organ symptoms. Gastrointestinal complications as a whole, is difficult to make a generalized sweeping statement, but as a whole, I would say they are relatively uncommon. In particular, serious gastrointestinal manifestations are rare. However, this does not mean that the patients who suffer from Marfan syndrome will not experience GI symptoms, which may affect them on a day-to-day basis. The symptoms can present in various ways, and it is important for any patients experiencing GI symptoms to please speak with a doctor, as there may not only be a functional or motility disorder, there could also be an underlying structural complication, and to highlight the possible link with the Marfan syndrome. Due to these symptoms not being a classic trait in Marfan's, out of all the interviewees, none of them were actually told about the potential gastrointestinal complications. And just to end with a couple quotes that the interviewees said, they said to keep fighting with Marfan's, especially with clinicians and doctors, and to try to get them to view you as a whole Marfan patient, not just someone who has, for example, GI problems. And one interviewee said it beautifully, there is more to Marfan's than you realize. Thank you for listening.
Thank you very much, Simon. That's the most erudite discussion of a rather rare problem. Do we have any questions for Simon left over from both our presentations on gastrointestinal problems today?
Not many do know there is a correlation between Marfan and gastrointestinal symptoms, but they are increasingly reported to the helpline, constipation and diverticulitis particularly.
Yes, it can go unrecognized for years, you know, and yet there is a solution. So the idea is not to blame everything on age, for example, but to have things investigated, because diverticulitis does tend to occur in the older population. And things creep up on you, you know, over the age of 50. These complications begin to arise when they were never there before. Sorry, continue.
Mariam asked, how do you treat incontinence for women? Even with exercise, it doesn't help.
Gosh, okay. With regards to incontinence as a whole, I'm not too sure, and it wasn't mentioned in any of the papers. So I think it would be really best just to speak to your local GP and also specialist, and they can give you the best guidance. I'm afraid I'm not too sure.
I think the answer, perhaps this is a subject for next year's students. It is more common in Marfan syndrome, especially in the women. Pelvic exercises to try and strengthen the muscles around the ureter and enable you to hold the urine longer are important. One can do a pelvic repair. And I think beyond that, we're probably into incontinence pads and pants and that sort of thing. But it is much more common, and also keeping your weight down is very important, because obviously the more abdominal obesity you have, the greater the pressure on the actual bladder itself. But I think to ask a referral, don't put up with it, ask a referral to a urinary specialist, a GU specialist, and there are modern solutions which you should know about.
And Jose has asked, if during your research, did you come across any foods to avoid?
Particular foods to avoid, I'm not sure, but I think it will just go the usual excess sugary foods, excess fatty foods, but in particular, foods which are good for you are high fiber foods. So a lot of people would then take stuff like bananas, etc., and that seemed to work.
Thank you.
Sometimes there are food sensitivities, not actual allergies, but sensitivities to lactose and gluten. And you can try eliminating those one at a time and see if things improve. But there are medications that are available, so don't put up with that either, because there are medications to help with bulking up stool and also decreasing the transit time in the bowel to treat constipation. So it is all treatable.
Can I just ask a quick question? Thank you very much for that excellent talk. Lots of hard work there. Did you get a feel of what kind of age people are getting these difficulties? Is it something I need to be concerned about in the children, or is this something that's happening in later life?
I think from the research, it was more adults. So I would say anywhere from late 20s onwards, so about 30s onwards. And this also corresponded with my interviewees. They were more adults as opposed to children. But in terms of the structural complications, I think there were 1 or 2 pediatric cases, but I think that's a lot rarer. So typically the adults population, yes.
Thank you.